Welcome to
No, ma'am.
another
Go ahead,
session.
ma'am.
Good afternoon, everyone. Welcome to another session from Oasis Fertility. Today, we're going to talk about fertility preservation. I'm Dr. Akhila, consultant, fertility specialist, Oasis Fertility, Gachibowli, Hyderabad. So, we have about 2 lakh patients who are less than 40 years who are diagnosed with cancer annually. And over the last 4 decades, the treatment for cancers have been so rigorous and advanced that there are many patients who are now walking into the fertility clinic and who seek fertility. So there has been a common consensus between the patients and the medical team that fertility preservation has to be offered, especially from the oncologist, and these patients have to be referred to a reproductive specialist. So fertility can be preserved before the damage happens to the gonads, ovaries, or the testes. And even though the awareness has increased over a few years now, the services related to fertility preservation, the counseling, everything is underutilized. So, in this session, I want to impress upon everybody what are the implications of cancer and its treatment on fertility. What are the options that are available to preserve fertility, and how to go about all this. So coming to the first aspect, what does the cancer do to fertility? In the first place, cancer itself causes a decline in the oocyte quality or the quantity, the sperm quality and the quantity. The intra-ovarian milieu gets disturbed once there is a cancer as such. So, for example, if there's a Hodgkin's or a non-Hodgkin's lymphoma, the AMH is reduced much less compared to in a woman who has breast cancer. So this is how cancer in itself causes fertility issues. The treatment of cancer causes more issues, which I will tell you a little later. The second aspect being time. Once a person is diagnosed with cancer, we are naturally in a state to expedite the process of treatment. Firstly, the cancer treatment. And before we go to that treatment, we want to do something to preserve fertility. So this takes time and it delays the treatment to cancer also. So this has to be balanced and taken into consideration. And for men, it is easier to store a semen sample. It is normal. For women, it is not as much. It's a little invasive to be able to preserve their fertility, which I will tell you in a couple of minutes from now. And also, the amount of injury that happens because of cancer treatments, the extent to which there is loss of fertility. It depends on what kind of treatment the woman is subjected to or the male is subjected. Whether it is only chemotherapy or a mixture of chemotherapy, radiotherapy, surgery, it all depends on what treatment basically is provided. And if chemotherapy has already been started, so then to preserve gametes is not advisable because it has got deleterious effects on the progeny. And a little bit about chemotherapy and radiotherapy. Chemotherapy, it depends upon what agent is being used and how long is the therapy advised for. So alkylating agents are gonadotoxic, and compared to the other agents, agents like chlorambucil, busulfan, and cyclophosphamide, these are some of the agents which are very toxic to the gonads. They cause oocyte atresia, and compared to the other drugs, these drugs cause a lot more harm. And even though sometimes women may get back their menstruation after the treatment of fertility is over. It does not mean that they have gained their fertility potential. Uh, they are at a high risk for premature ovarian failure, and that is because the number of oocytes they they get depleted because of the treatments that they have undergone, chemotherapy or radiotherapy. Now, coming to radiotherapy, it not only has an effect on the ovary, radiotherapy also has an effect on the uterus, the HPO axis. If the uterus is, then there could be fibrosis in the uterus, and we need to measure the uterine volume and see if it's capable of holding a pregnancy. Even if it does, the risk of miscarriages, preterms, fetal growth restrictions, placental abnormalities, all these are higher in women. Also, what we tend to do is a single embryo transfer in these kind of women. These are some of the implications of what cancer does in terms of a little bit about what are the different options that are available for us to preserve fertility. It has to be done in both males and females. So first, coming to the males, it is slightly like I have already mentioned. It's a little non-invasive to store the semen sample. Traditionally, it's through masturbation that the semen sample is stored, but in some cases of azoospermia or severe oligospermia, or when there is no ejaculate, then a TC can be done. Also, there is something called as an onco-TC, where after orchidectomy, that is once the testes are removed for any cancer condition, sperm extraction is done after that. So this is called as onco. Coming to what to do in a woman to preserve her fertility. So it is usually an IVF that we suggest, and it means that we give some injections to stimulate the ovary and grow the eggs that are seen, and we pick up all those eggs, and there are two things that can be done once the eggs are picked up. One, store the eggs, or mix it with the partner's sperm and make embryos and freeze them. Embryo freezing is better than just oocyte vitrification. But there are some conditions like women with probably breast cancer or BRCA1 or 2 mutations. These type of patients, IVF may not be that much applicable. We have another modality, that is IVM, in vitro fertilization. That can also be done, wherein the hormone injections are not given for a prolonged period of time, that is 10 days or 12 days. They usually give it for about 3 days, and the immature eggs are taken, and we either mature those eggs and make embryos or the eggs are closed. That these are the two options that are available. Now, the other modality to preserve fertility is oocyte cryopreservation and transplantation. This is done in pre-pubertal girls, and what is done is the ovary is taken and it is cut and stored, and after the therapy is over, it is transplanted again into the body. It takes about 2.5 to 3 months for the hormone activity to start, and it lasts for about 7 years. Also, another in conditions with leukemia, this is not really applicable because the resealing of the tumor cells can happen. And one more option of fertility preservation is ovarian transposition. That is, ovaries are normally situated in the pelvis. So when there is radiotherapy or going on, take the ovaries and put them in the abdomen instead of it being in the pelvis. So one clinical aspect to this is that when the eggs are being received, it has to be done through an abdominal procedure and not a vaginal. Also in patients with cervical cancer, this is another condition where the retrieval of the eggs is done through an abdominal approach than a vaginal approach. These are some of the modalities where these are different options of preserving fertility in males and in females. Now, what is the impact of these IVF procedure or the drugs on cancer? How does this affect the cancer? Because like I have already mentioned, there is a time lag between the diagnosis and treatment to cancer. In this time frame is where we are offering this fertility preservation process. Now, first thing is obviously there is this delay in starting the treatment with your onco specialist. That has to be discussed. How much delay is possible, and is a multidisciplinary approach. So, an oncologist has to be informed about the treatment and the tentative duration of the treatment. Also, in some conditions like breast cancer and endometrial cancer, this is a stage where already there is an excess of estrogen in the body. So when we try to preserve fertility, we give injections which cause increase in estrogen in the body, which could be deleterious to the already existing conditions like breast cancer and endometrial. So what we do is we add on a few other drugs like tamoxifen or letrozole in patients with breast cancer to reduce the estrogen levels in the body, and it has as much efficacy as the other gonadotropics that we use. Alongside with that, in patients with endometrial cancer, tamoxifen is not used, and we use letrozole to reduce the estrogen levels. So these are the two things that have to be considered. One is the time frame, and the other is how to limit the hormonal estrogen exposure. How do we balance? So these two have to be kept in mind. The next thing is how do we prepare a patient for IVF? The moment the patient comes in, without wasting any time, the normal approach is to expedite the process, and we do an immediate scan to see how many follicles are there, how many what is the right number, and run a few tests. And what is called as a random start IVF is that is irrespective of the day of the we try to start off the IVF process. And counseling, duration, all these are some of the aspects that have to be told to the patient and communicated with her the oncologist as well. And apart from this, some of the complications have to be dealt in very deeply, and we need to make every effort to prevent these complications because of IVF, because that will further delay her treatment to cancer. So one of the major side effects is OHSS, that is ovarian hyperstimulation, prevented at some cost because this will delay her further process. And the other complications could include extension. And regarding the follow-up, normally we call our patients after IVF on the third day and the fifth day. We do scans, how the ovaries are, and whether she is developing this OHSS syndrome, which is because of fluid accumulation in the body. We will not be able to do that because the patient would already be in her oncology setup getting that treatment. So phone calls and rigorous follow-up over the phones has to be maintained to make sure that the patient is doing well. And consents also have to be definitely taken in that should the patient not survive her cancer treatment, then what do we do with the cancer? Whether they're given to the partner, whether they're discarded, donated, or for research purpose, all this has to be kept in mind. And another aspect is about childhood cancers. So, some of the cancers affect children with fertile groups, and the methodologies in treating this has dramatically improved. So now we have a lot of patients walking in their adulthood who are cancer survivors. So, fertility preservation in these patients, the options that I have already. And once they do come, we have to carefully evaluate them, evaluate their cardiac condition, make sure that there are no arrhythmias, cardiomyopathy, and pulmonary fibrosis. All this has to be out. If the uterus is irradiated, what is whether it can hold the pregnancy or not, is something that we have to look at. Also, what I would want to impress upon is that if a childhood cancer survivor does become pregnant after IVF, the chance of live birth is similar to any other woman undergoing. Apart from cancer condition, the other fertility preservation is also applicable to those women who are building up their careers, who are busy and not postpone their fertility for any reason. Even those women can utilize these options and save their fertility potential. Um, this is about, in brief, about fertility preservation. If any questions are there, thank you. So one question is, what are the methods of fertility preservation? I've already mentioned all the methods. There are methods for the males and females. So in males, it's normally a semen freezing that we do traditionally through masturbation. We can collect the sample and store it. If time permits, 3 or 4 vials. Otherwise, if the treatment is the oncology treatment has to start immediately, at least 1 or 2 samples can be stored. And if there is azoospermia or severe oligospermia, or he is not able to ejaculate the sample, then it requires an invasive procedure, TC, or another way of doing it is onco-TC, where after orchidectomy, that is the testes are removed, we take the sperms from there and store it. This is for males. And for females, fertility preservation is done through IVF. That is, we start the process soon after the woman enters the clinic. Quickly, injections are given. The eggs are grown to a particular size, and after looking at them with the ultrasound, once they are of a sufficient size, we take those eggs, and either the eggs are preserved or they're mixed with the partner's sperm, and embryos are formed, and the embryos are preserved. If she is pre-pubertal, then ovarian tissue is taken and it is cryopreserved. Once the treatment is over, we transplant this. The other way of doing it is ovarian transposition, where the ovaries, where they're in the pelvis, they are repositioned in the abdomen to prevent the effects of radiotherapy. And after that, it's again an IVF that is stimulate the ovaries, get the eggs to grow, pick up these eggs, mix it with the partner's sperm, and embryo transfer. So these are some of the methods of fertility preservation. It can be done in the, what is the age for fertility preservation? It can be done in the reproductive age group, pre-pubertal, that is young girls who are less than 18 years and who are in the reproductive age group, and even women who are in their late 30s, 40s, all these women can be subjected to these procedures. What is IVF for fertility preservation? So IVF is normally it's a random start that we do, that is without wasting time. Once the woman walks into the clinic, traditionally the IVF we usually start on the second or the third day of the cycle, but we don't wait for that time because she doesn't have time in her hand. So what we do is we start off with the gonadotropin injections as soon as she comes into the clinic after preliminary examination and ultrasound and a few blood tests that we do. And it's usually an antagonist protocol. This is chosen to take every step to prevent OHSS and give the gonadotropin injection, get the follicles to grow, and we pick those follicles. This is IVF for patients with cancer. Call it the random start IVF. What is the benefit of fertility preservation? Okay, the benefit is that the patients are able to use their own genetic material instead of going for a donor egg or a donor sperm at a later date. So their own genetic material is used, and that is the biggest advantage of fertility preservation. Any other question? Thank you so much. Thank you.